Well, guys, welcome to Ivy League Learning. We're glad you're here. I'm going to turn over the con here to Dr. Jacobs, and then we'll get going.
Thank you, and welcome everybody. Tonight's topic is vascular access considerations for patients with lymph node involvement. So that's a topic that comes up for discussion a lot. And our speaker tonight is Judy Thompson. Judy is the Director of Clinical Education for AVA, and she's been filling that role since 2018. She's also past president of AVA and chair of the D team. She has a professional background in telemetry, ER, oncology, outpatient surgery, and of course, vascular access. So welcome, Judy, and I'll let you fill us in about lymph nodes.
Thanks so much, Kristen. You filled in a lot of my bio. I sent you one sentence.
I know. I had to do more.
Okay. Well, guys, thank you so much for being here. First and foremost, I did want to start off with just a moment to recognize that our founder, Suzanne Herbst, did pass recently, and she's just a wonderful woman. And one of the messages I sent out was, when you think of what one person can do, if you ever think, what can I do? I'm just one person. Just take a look at this woman. We are here because of this one woman's vision. So she was wonderful. She had a vision, and I was very, very, very lucky to have known her. So just wanted to pass that on. And she was a character too, man. She just had such a great sense of humor. Love the woman, and I hope she's up there putting in IVs. So we're going to talk about considerations for patients with the lymph node involvement. And as Kristen said, I do work for AVA, but I do need to tell you that the opinions I'm going to share today are my opinions and not necessarily those of AVA, nor are they the opinions of the board of directors. If there are any that AVA does share, for sure, I will mention it, but for the most part, just assume they're all mine. We're going to talk about a couple learning objectives first. Although this is not a CE event, I did want to talk to you about a couple of things in particular. So we're going to talk about some of the challenges of patients that have breast cancer and lymph node involvement. And also I want to discuss some of the current evidence and trends regarding lymphedema and the restrictions we put on our patients oftentimes. So let's get right into it. It is staged in 4 different stages. It's a chronic, progressive, and debilitating disease, really characterized by swelling, accumulation of protein-rich fluid, the lymph fluid, in the interstitium. And it's due to the mechanical failure of our lymph system. Let's talk about these and really about what's going on. In stage 0, the lymph system is impaired at this point, but it's still functioning. It's still functioning, but a little bit inadequately. You won't see swelling. You won't see any of that edema, but you know that there's some problems going on with it. Stage 1 is where we start to see some of that soft pitting in the affected area. It could be in the arm. Generally, the folks that we worry about with lymphedema have had a breast cancer with lymph node involvement, and then we see one of their arms, hopefully one, if not both, affected, and we'll start to see some of that swelling. Generally, you'll see that pitting edema. So if you touch them softly, you'll get a little bit of a pit, but then if you raise their arm, put it on some pillows, it'll go away on its own. And that's good because it's reversible. It's stage 0, stage 1. Those are reversible lymphedemas. When we get to stage 2, however, it starts to be an irreversible condition. And this is when and you can see by the pictures here, the swelling is increased. It's not reduced when we elevate their arms at all. The tissue starts to harden, it starts to thicken, it starts to get fibrosis and sclerosis. Indentations are not going to be a soft touch, it's going to be a push to get it to indent. And at this point, they're going to have an increased risk of infection as well. Now, getting to stage 3, this is debilitating. It's extreme. It's hardened. You'll have some crevasses in the skin. where they're going to have skin breakdown and some infection possibly. Large bulges, possibly some wart type skin. And it's so impaired, they have poor healing wounds, infections, and this is a really tough stage for folks to be in. So there's different types of lymphedema as well, not only in the staging, but the type of lymphedema that comes with it. If you look at the picture in A, this is a pediatric primary lymphedema, and this is caused by insufficient lymph system at birth. So you'll see swelling, pitting, the whole bit of the stage 0 through 3. The second picture in the B, that's again a breast cancer that was treated either lymph node removal, could be radiation, could be a lot of issues with that. And that's either a 3 or a 4 with her arm. So in the picture of C, that is a secondary lymphedema caused by a cancer where they've done some lymph node removal, and that was due to a cancer. And then D is a bilateral obesity-induced lymphedema. So that is never going to go away either, unfortunately. So let's talk about the lymph system as well. It's not just the lymph nodes and the capillary pullbacks. We have the thymus, the bone marrow, the spleen, tonsils, appendix, and Peyer's patches in the intestines. All of these play together to create our lymphatic system. What are 3 of the main functions of our lymphatic system? So we've got fluid balance, absorption, and the immune system. So all of these are really important functions of the system. And when it becomes impaired, we come up with big problems. So it's not just always about that swelling. The lymphatic system returns excess fluid and proteins from the tissue that can't return through our blood vessels. The fluid often collects in these tiny interstitial spaces. The small lymph capillaries around these spaces pull it back into the lymph system. About 90% of the plasma that reaches our tissue from our arterial system returns through our venous system, but the other 10% actually returns through our lymphatic system. So that's part of the fluid balance. Absorption. Our lymphatic system plays a key role in our intestinal function as well. It assists in transporting fat, fighting infections, and removing excess fluids. One of the big takeaways too, it's not just about swelling, it's about our immune system. And our lymphatic system plays a huge part in our immune system. Our body has its main ways of fighting infection. We've got our physical barriers, our skin. Then we have our toxic barriers like this acid base in our stomach. And we also have our friendly bacteria in our body. But when that bacteria get past those systems, our lymph system takes over. So in our lymphatic system, we create the white blood cells, lymphocytes. Kind of the reminder, we make the T cells and the B cells there, and they travel through the lymph system. When they see a bacteria, they go after it. Those are our 3 functions in our lymphatic system. Not only do we need to worry about lymphedema, but when our patients present with a breast cancer with lymph involvement, we need to have a heightened sense of importance about our infection prevention practices. We know that if they've had we don't know this because there's not a lot of evidence in this practice actually about lymphedema and the lymph system. And I can see why. Who's going to get through IRB saying, we're going to test out this theory to see if there's going to be a problem if we start putting lines in patients that have lymph node involvement. But, right now we're saying, well, we're not going to put a line in a patient that has, we've had sentinel nodes removed and maybe a dozen others, but we'll put a pin in that and come right back to it. So most patients who have lymph node dissection or radiation will experience lymph swelling, tightness, heaviness, or aching pain within 6 months to 3 years afterwards. Most patients will. That's frightening. And that's just saying that the dissection itself plays a key role in it. But on top of that, let's say they only had a sentinel node removed but then they went and had radiation. That plays a huge part in it as well. So that patient is far more likely to become positive with lymphedema than the patient that didn't go through that. So a couple facts about the lymphedema. It affects between 90 and 250 million people worldwide. Patients with lymph node positive breast cancer have a 22% of lymphedema. Now, patients with a lymph node negative breast cancer still have a 6% incident rate of lymphedema. 6%, and they're negative. So they did a sentinel node biopsy, it came back negative, they didn't do others, but 6% of them will still progress to lymphedema. So at-risk individuals are anyone who has had lymph nodes removed or radiation therapy as a treatment for cancer, whether it be in the leg, the arm, what have you. And generally the onset is insidious. So maybe that patient will start complaining of tightness or discomfort. Those patients are becoming positive with lymphedema, and we need to move quickly. So some of the symptoms: swelling, burning, tightness, pressure, aching. And these are progressive symptoms. Then it goes to skin discoloration, impairment, joint immobility. Then difficulty walking if it's lower leg, obviously. Problems with ADLs. And then as it progresses to stage 2, 3, open wounds, cellulitis. And then they come back with the fibrotic hardening of the skin. Medical procedures and arm use with this is still quite controversial. There's a lot of different theories out there. Some saying we can put a line in these people, it doesn't matter whatsoever. And others saying you can't touch them. So where do we go? It's such a hard topic. I don't know why I picked it to present it to y'all today, but nonetheless, there's a lot of historical myths and advising arm restriction, limited activity. But the current practice is to recommend activity and return to healthy lifestyle, not an inactivity and avoidance. So we want our patients to use those arms. We still have concerns about putting lines in these patients. So we have a bevy of options when we comes to devices, especially if that patient needs chemotherapy. I think with breast cancer, probably the safest line to put in with these patients is probably a subcutaneous port. But regardless, if they have any involvement in the lymph nodes, and they will if they're going to be getting chemotherapy, I'd recommend staying out of their arms personally. So I would go inside the axillaries. Stay away from PICCs, in my opinion. There are no perfect devices. Each one has its risks and benefits. Everything we do does matter. Now, quick story. I had a patient, this is years ago, that I went to go see. She had, I think, 12 nodes removed on one side and a sentinel node on the other. And I talked to her. I said, you know what? I don't really want to place a PICC for you. I don't believe it's your safest choice. And here's the reasons. And it was about infection and lymphedema and all those good things. And I said, what I'd like to do is put one in your IJ or in your axillary, and you can use it for the remainder of your treatment. And we talked about all the risks and benefits. And after 45 minutes with this woman, she said, you know what? I understand the risk and benefits, and I want a PICC. I want it in my arm. And it wasn't my favorite choice for her, but I documented everything very clearly, and I placed a PICC for her. So still, remember that the patient really does play a part in these as well. And we have to do what's right for them. And they need to have a voice in their care. She understood she had an increased risk of lymphedema. I did follow her for about 2 months. And in that 2-month period, she did not have any lymphedema symptoms. But again, 2 months doesn't play into this too well. And I did lose track of her, so I don't quite know what happened. But just remember that, as Jack LaDunn says so clearly, that the insertion is a fraction of the life of those lines, and care and maintenance is the majority of it. So just be mindful how we put it in, where we put it in, where the dressing is, and how comfortable it is for that patient, because they're going to live with it for many, many, many hours. Kind of just a eye chart here, but If they've had any positive breast cancer, or positive lymph nodes, don't go to their arm ever, unless, of course, the patient requires it of you. If they've had negative breast cancer or negative lymph nodes, consider not going to their arm, please. Medical procedures and arm is still controversial. So off and on, I don't know. Maybe not put a PIV in them too frequently. But the current practice is to recommend activity, not inactivity. So don't make them baby their arm the whole time. And go to their neck. Remember radiation. Remember they're at higher risk for infection. And it's not just about lymphedema. But if your patient begins to have symptoms, there's treatments. And it's really important to hit the treatments quickly. Don't wait until it's full-blown. Conservative is complex decongestive therapy. Then surgical, they can actually do a lymphatic bypass. There's other things they can do as vascular surgeons. So it's not game over if they get to stage 2. I don't know about stage 3, but watch them closely. That's really important. So with that, thanks. And if there's questions, I would love to answer any. And I'm going to stop sharing so we can put people's cameras on.